So this is GJ, 78-year-old male. Talked about him last Thursday. He underwent a T10 to pelvis at an outside institution last fall, and subsequently developed this pretty severe osteomyelitis discitis at the cephalad to the prior spinal fusion. The T8, T9 vertebrae were significantly eroded. The disc was completely eroded, and he ultimately developed this sort of collection anteriorly. He was admitted to the hospital in that void, which was thought to be an abscess, essentially formation of an abscess in that void there. He had been admitted to the hospital a few weeks ago, about 3 weeks ago, for IV antibiotics for culture via IR, biopsy and culture of this region. Ultimately grew out an organism called Staph lugdunensis, and he ultimately underwent a revision posterior spinal fusion last week on Friday. So this was a great case. I was really happy for this gentleman that, basically we had talked about quite a few different options based on what we would find in the operating room. When we opened his spine posteriorly, there was no evidence whatsoever of any infection in the posterior column or posterior aspect of the spine. So we took out the T10 screws, and there was no evidence of infection. They were not. I wouldn't say they were monster bite in those T10 screws, but they were not grossly loose. And we removed them, and then we did a end-to-end connector and put 8 fixation points above the T8 level where the infection stopped, and did a 4-rod construct across this defect. The plan going forward is to likely take him back to the operating room for debridement of the anterior infectious tissue, and do a corpectomy and cage for structural support anteriorly. And he did really well. He left post-op day 2, and he was feeling better, clearly due to the stability that was provided him across this highly unstable segment. When we put him on the operating room table, this really, we didn't actually need much reduction or correction further than what you see here. So this sort of significant kyphotic deformity in the upright position really sunk down into this, what you see here, fairly corrected fairly easily, which was nice. So really, really good case. My fingers are crossed for this guy, big time.
Could you show that long film again?
Yeah. So we basically put the chest pad pretty high up, so as to allow, and the pelvic pads, right over the ASIS, but that allowed for this entire segment to really sink in.
And we built the hips up too, right? We tried to create some extension moment across the defect.
Yeah, I forgot about that. That was pretty helpful as well. Just a few towels under the hips allowed the spine to sink in a little bit more into the Jackson table and correct that deformity just on its own with gravity. And it slowly corrected from the time we were taking our initial pictures. It corrected probably another 10 degrees throughout the case until we actually started with our instrumentation and rod placement.
So is the plan definitively to go back and do a corpectomy once the infection is burned out?
I mean, I don't know that it's going to be totally burned out. His inflammatory markers were on the rise, and kind of it's unclear whether it's going to actually burn out entirely. I mean, I think the fact that he had so much instability was clearly contributing to the sort of infection bubbling over. But I don't know, Dr. Isak, my thoughts are that we should take him back for structural support.
Yeah. The
regardless of the
main
infection.
idea, I think, was that we're concerned that the infection will need debridement, but we didn't want to do it concurrently with a clean posterior envelope, or what appeared to be a clean posterior envelope surgery. So we're just going to slightly stage so that we do our best to keep the posterior side clean while debriding the ventral side by a week or two.
Okay.
I'm just gonna bring it up. So the thought that the correction may be too much. He's got a really lordotic lumbar spine from all those interbodies and what they did ahead of time. You have to be a little careful. This may not be the case. I don't know the numbers here, but you just be conscientious of how much you straighten a PJK. Because sometimes the PJK results as a compensatory factor for what's happened below. So he may be a hair overcorrected even down low, and
I don't disagree with you, Greg, but it's not a true PJK. It started 2 levels above with an infection. But I your point's well taken. We did not fully correct him. I think we got him down to 16, 17 degrees, something like that. Versus neutral through that area. So he still has some kyphosis.
Never be neutral. Sure. Yeah, you don't want that neutral in the thoracic spine.
Right.
I mean, Dr. Islak, do you think that this is a random discitis osteomyelitis, or that it might be instability at that level that caused the problem?
No. He had a discitis at T8-9. It was 2 levels above. And so, and the posterior envelope was totally clean. So I think it's just a random, weird, spontaneous hematologic or hematogenous spread. But, with the physical stress at the proximal junctional area, in addition to the infection, obviously caused a catastrophic failure, and then eventually communicated to the T9 body enough to create more and more failure. It was pretty dramatic how dynamic he was through that area.
Yeah.
So just going to touch on staph lugdunensis, since it came up last week and everybody was sort of scratching their heads. I'll take a couple minutes to run through this. So it's a unique coag-negative staphylococcus, and it resembles Staph aureus in its pathogenicity. It's part of the normal skin flora, but and is associated with normal other types of skin and soft tissue infections, and can also be associated with PJI and endocarditis. It's a coag-negative staph, but the virulence is often underestimated because people think of coag-negative staph like staph epi, etc. But this one actually is more virulent and does act more like Staph aureus. So it can have adherence factors and biofilm formation that is readily present, and it's becoming more sort of more understood and associated with high morbidity and mortality. It's, as I mentioned, PJI, other bone and joint infections, and vertebral osteo and discitis, as we saw in this case. It's often nosocomial because as does staph epidermidis, it does often colonize central venous catheters, etc., in the hospital setting. It is often highly sensitive to antibiotics, so that's the good side of it. But because of its virulence, it has a high morbidity and mortality nonetheless. There was a study that looked at 70 isolates, and 80% were beta-lactamase resistant, 10% were oxacillin resistant. So commonly beta-lactamase resistant. And oftentimes it's underreported in laboratory settings. But unlike staph epi, where sometimes you think it's a skin contaminant, staph lugdunensis should be presumed as a true pathogen when you see it come up on a culture. Okay, let's see. I just mentioned that. As I said before, pathophysiology is often related to skin colonization or central venous catheters, etc. Transient bacteremia could potentially result in hematogenous seeding of the spine, as we saw in this case, which we presumed is the mechanism in our patient. And it could have even been seeded, during his initial surgical or hospitalization. No definitive infectious disease consensus in terms of the optimal treatment or duration in vertebral osteo in the setting of required hardware placement. In native vertebral osteo, the ID societies recommend at least 6 weeks of IV antibiotics, and others recommend 6 to 12 weeks, and then some others still recommend 3 months of oral suppression when Staph aureus is involved as well. And then when there's hardware, it can be even more difficult to achieve a cure due to biofilm formation, as I mentioned. So that's just a brief overview of Staph lugdunensis. Keep your eye out for it. It's not your normal coag negative staph like Staph epi or others. It's a more virulent organism. So when you see it, take it seriously. That's all I got.
Did you find anything like that in the spine or not?
So the posterior spine was completely clean. We did not see any.
Oh, I meant literature.
Oh, in the literature. Yeah, as far as vertebral osteomyelitis, it's becoming more commonly found in vertebral osteo. And with respect to anything specific, there's not a ton of literature out there specific to the spine, but there's a couple articles that mentioned it, and there's a couple case reports. There was one case report of a cervical spine epidural abscess of Staph lugdunensis. A lot of the other case reports and some of the literature mentioned that Staph lugdunensis can be common in immunocompromised patients. One article talked about a patient that was on chronic steroids for rheumatologic reasons and had a very virulent and difficult infection to treat in the lumbar spine, osteodiscitis with Staph lugdunensis. So, it's out there. I don't, have any further information than that. I can. Like I said, there were a few case reports and certainly some information out there.